So thank you very much, Sharon Lee. That really, I think, sort of puts together a bit about the importance of what we're doing here today, and I really appreciate your ongoing support. And it really also ties in very nicely to our keynote speaker, who's Tara Gomes. So we heard a bit about Tara, but Tara is an epidemiologist, and she's a principal investigator of the Ontario Drug Policy Research Network. And I think this is a really important group of researchers that get together, and they create research that is done really quickly to respond to important needs. It really helps decision makers in Ontario and beyond. So it's very, very important work. She's also a scientist at Li Ka-shing at St. Michael's Hospital and at the Institute for Clinical Evaluative Sciences, as well as having an appointment at the University of Toronto. And as you've kind of got a sense of, her research does focus on drug safety, and she has made a huge contribution in the area of opioids. And I've also had the personal pleasure of working with Tara on projects and publishing with her, and I can attest to the quality of her work. And so we're really delighted to have you with us today, Tara. So welcome.
Thank you, Paula, and thank you everybody for having me here today. I'm really pleased to be here to speak with you about some of the research that myself and my colleagues have been doing over the past little while, trying to really understand what is happening in Ontario and more broadly across Canada as it relates to opioid prescribing and outcomes, and more specifically, how those patterns differ between men and women. I come at this from a very quantitative lens. I'm an epidemiologist by training, and I tend to look at large databases to try and understand what patterns are happening at the population level. So a lot of my presentation will focus on that, but I'll also touch on a little bit some of the work we've been doing more recently with focus groups with patients. So it's really nice to see that video of Tracy at the beginning, because I'm becoming more and more convinced that we really are going to get nowhere with this issue if we don't speak to people with lived experience and understand their perspectives, because it can not only advise policy reactions or clinical responses, but it can also really be amazingly helpful in informing what we study and what research we choose to do. So I'll touch on that a little bit, because I think just in the last little while as we've moved into that area, I've learned a lot, and I think that's really helped contextualize how I think about the data that we see as well. So starting off in terms of prescribing trends, so to give a sense of where we are in terms of how we get here, I just want to spend a little bit of time thinking about how we got here in general in Ontario. So what happened? How has prescribing and related adverse events really shifted in the province? And this is simply a picture of opioid prescribing trends across the province for the last 25 years. And what we saw in the 1990s was really a fairly steady rate of opioid prescribing in Ontario, which changed really in 2000 with the introduction of OxyContin, a long-acting form of oxycodone, to the formulary here. And at that time, we saw this really sharp increase in the overall rate at which opioids were being prescribed across the province, as well as seeing that that was really being driven by the darkest part of this bar, which is the oxycodone prescribing. So a lot of that was attributed to the heavy marketing that existed around OxyContin when it was introduced to the market in Canada in around 1996 to 2000. What we also see, though, in the most recent few years is a shift again in that pattern of prescribing. So in 2012, the manufacturer of OxyContin introduced a tampered deterrent form of that product. So they pulled OxyContin and replaced it with OxyNeo. And the idea here was to try and address some of the misuse that we knew was happening with OxyContin, with people crushing the tablets and inhaling them or dissolving them and injecting them. And so this tampered deterrent form was supposed to kind of dissuade people from misusing the oxycodone products in the same way. At the same time, the ministry introduced some new policies around access to that drug and how it was reimbursed. So what we saw was this actual reduction in overall prescribing of opioids across the province when OxyNeo was introduced. And a lot of that contraction happened with the oxycodone, that darkest part of the bar. But we also saw this really interesting phenomenon, which was that we started to just see different shifts in the types of opioids that were being prescribed. It's this concept of squeezing the balloon that we often talk about here, in that addressing one type of opioid that is problematic right now is not going to solve this problem, and instead you just shift people between different prescribed and other drugs. So we did see some reduction, but we also saw some important changes with hydromorphone becoming more and more involved in opioid prescribing across the province. When we think about opioid-related harms, this is simply a trend in opioid-related deaths in the past 25 years in Ontario. And you can see that we have seen enormous increases, as was already mentioned, in the rate at which people are dying of opioid-related causes. With similar patterns early on, in the 1990s, we were at a pretty stable state of opioid-related deaths. But again, in 2000, when OxyContin entered the market, we saw this change in trajectory of overdose deaths. And when we look at the types of drug involved in those deaths, it was predominantly oxycodone that was involved in these deaths. But the difference in this pattern to what we saw on the slide before is that in 2012, when we started to see some shifts in prescribing, we have seen no change in rates of opioid-related deaths, and probably have seen an increase in the rate at which people are dying of opioid-related causes, particularly in 2016, where you can see such a big rise. And that really raises the question of what's happening here, and these huge concerns that we have, that we created this cohort of people with an opioid use disorder due to overprescribing in this province. And then by introducing policies that were well-meaning to try and promote more appropriate prescribing, we are now pushing people into the illicit market that we know is inherently less safe and is leading to these huge changes and increases in the rate at which people are dying of opioid-related causes in the province. And finally, kind of bringing this back to a societal or public health impact, I think it's important to kind of consider the burden that this is having on us in society. This is a figure from a paper we published a few years ago, looking at the proportion of deaths within different age groups that are attributable to opioids. And you can see that each line represents a different year from 1992 up to 2010. And by 2010, we see in the young adult population, those aged 25 to 34, 1 out of every 8 deaths was attributable to an opioid overdose. So just let that sink in for a second. 1 out of every 8 deaths in young adults in Ontario was from an opioid-related cause. We recently updated this in 2015. It's now 1 out of 6. And the youth population, the 15 to 24, has suddenly jumped up. So 1 out of 10 deaths in 15 to 24-year-olds are now from an opioid-related cause. So I think this just drives home the point of the huge contribution that this is having to early loss of life in Ontario, and also just the broad societal impacts that can have across our communities. Our first foray into trying to really understand this issue as it relates to how it might differ between men and women was a study that I worked on with some colleagues that was published a couple of years ago, where we looked at people who became chronic users of opioids. So they continued opioids for at least 90 days. And we looked at what their risks were for escalating to high doses of opioids that we know are particularly dangerous, and as well their rates of dying of an opioid-related cause, and compared that between men and women. And we saw some interesting differences. So we saw that men were much more likely both to escalate to high doses of opioids, and were had a twofold increased likelihood of dying of an opioid-related cause. So this was our first opportunity to kind of understand where there may be differences in the prescribing patterns and the harms related to opioids across the province. But we had this problem that is a problem that we've had for some time, which we're only really starting to be able to address with the data that exists at the population level in Ontario, which is that until recently, when we looked at prescribed drugs that were dispensed, we only knew what was being prescribed and reimbursed by the government. So these are generally people who are over 65, or if you're under 65, you generally have low socioeconomic status or are eligible through Ontario Disability Support. So this population is very different from our general population and tends to be a little bit more heavily weighted towards women. And so we didn't have a sense of generally across the province what was happening with opioid prescribing to the broader population. And this changed in 2012 when the government introduced the narcotic monitoring system, which captured finally all opioids that were being dispensed at pharmacies across the province. And this was really helpful for us because we now knew we would have a data source to understand what these patterns were and better understand how they impacted different populations. Unfortunately, we didn't get access to it until earlier this year, so there was some time in us actually getting access to it to analyze it. So some of our research in this area is pretty new, and we're still trying to figure out how we can leverage this data to really inform what's happening. But what I wanted to do today was just go through some of those preliminary statistics and research that we've been doing to try and get a handle on what's happening at a population level and specifically between men and women as it relates to opioids across the province. So this is it looks kind of boring, but this is a pretty simple figure of opioid prescribing across the province to treat pain. So the dark line is women and the lighter line is men. And you can see that we've been in a pretty stable state, as we already know over the past few years, in terms of general rates of opioid prescribing. But women historically have continued to be prescribed opioids at a higher rate than women, and that hasn't really changed over time. Consistently, women are being prescribed opioids at a higher rate. If we look at 2016 alone and look at opioids used to treat pain, which is the vast majority of opioids that are dispensed in the province, we see that about 13% of women in 2016 received a prescription for an opioid, compared to about 11% of men. Another indication that people don't talk about a lot is opioids can be used as a cough suppressant as well, and we see a similar trend in that women are more likely to be prescribed opioids as a cough suppressant. And there are a number of reasons why we think that this might be happening. We know that in general, women tend to sometimes be prescribed drugs in general, just more than men, but there are also important trends around chronic pain and the prevalence of pain and the opportunities for women to be exposed to an opioid through a prescriber. So in older men and women, we see that women tend to report a higher prevalence of chronic pain than men. And also there are some indications that just are more prevalent in women than men. So if we think about childbirth, we see a fair amount of opioid initiation following childbirth. Arthritis, which tends to occur more in women, is another way that people often get exposed to opioids. And migraines. And even in these focus groups I mentioned, we spoke with a number of women who said that their first experience with opioids was menstrual-related migraines and having a doctor prescribe them opioids to treat that, which is not an indication for opioids, but speaks to the overprescribing and the way in which that may have targeted and landed more among women than among men. But when we shift from the prescribing to the outcome side, we see slightly different trends. So this is, again, the rate of opioid-related deaths, or the number. The rate figure looks almost identical in opioid-related deaths by men and women. And we see that men are more likely to die of an opioid-related cause compared to women. And back in the early 1990s, we had closer numbers in terms of that distribution between men and women, and that has grown over time. And even just in 2016, we see this jump in men that we don't see among women, that I think is partially attributable to the illicit fentanyl and other synthetic opioids that are pouring into the market on the illicit side that seem to be perhaps impacting men more than women. But when we look at non-fatal overdoses, we see a slightly different trend. We see that men and women are fairly similar in terms of their rates at which they're having non-fatal opioid overdoses. So women are prescribed opioids at a higher rate than men. They have a similar rate of non-fatal overdoses, but men seem to be dying at a higher rate than women. So it's really interesting to try and then tease out what are driving these different trends and what are the drivers that we can actually impact to understand how to address this issue. And one of the things that I think is important to look at is what are the types of opioids involved in these deaths, and what are the types of other drugs involved, because most deaths that occur that are related to an opioid have other drugs that contribute to those deaths as well. And so we looked at all of the death investigations for opioid overdose deaths at the coroner's office for the past many years. And this was in 2015, where we looked at what were the drugs involved in those deaths. And when we look at illicit drugs, so cocaine, cannabis, heroin, as well as fentanyl, which has both prescribed and illicit sources, we see that men are much more likely to have those drugs in their system at time of death compared to women. But if we look at prescribed drugs like benzodiazepines, antipsychotics, antidepressants, those are much more prevalent among women compared to men. So we see really important differences in the drivers of the opioid-related deaths in terms of the types of drugs that are actually contributing to those deaths. We also were really curious to better understand the degree to which prescribed opioids were contributing to opioid-related deaths, because that's been a question that's been outstanding for quite some time, is with the crisis that we're in right now, how much are the prescribed drugs actually contributing to deaths versus illicit drugs that are either diverted or synthetically produced and purchased on the street? And so what we did was we linked these deaths, these opioid overdose deaths, to prescription records to understand, did somebody have an active opioid prescription at time of death? So had they recently gone to a pharmacy, been dispensed an opioid, and that duration of that prescription overlapped with their time of death? And what was really interesting for us in this is the huge divide that you see, again, between men and women here, where about half of women have an active opioid prescription at the time of death, as compared to only about a quarter of men. If we think about some other characteristics of deaths to try and put together all the pieces of the puzzle, we can think about manner of death. So are these typically accidental deaths or are they suicides? Predominantly in men and women, these are accidental deaths, and that's something that has been very consistent over time. We do see a slightly higher proportion of opioid-related deaths that are determined to be suicides by the coroner among women, and that's likely tied to the fact that women tend to use poisoning as a modality for committing suicide compared to men, and so it's likely that suicide is more overrepresented in the women in these statistics compared to men. But I think more broadly, the fact that the vast majority among both men and women are accidental is really important to remember. And then finally, thinking about age, and this was actually a figure I created only for this presentation because I was trying to understand that combination of age and gender as it related to opioid-related deaths, and I was really surprised by what I saw. So the light line again is men and the darker line is women, and it's so interesting to see that among women you see a huge skew in that distribution towards opioid-related deaths occurring between the 40s to 60-year-old women, with a little bit of an elevation in younger women, but it's not anything compared to what we see with men, where we see in late teens, early 20s, a huge increase in the number of men who are dying of opioid-related causes, and that's fairly stable throughout their adulthood and into their early and late 60s. So the reason I presented all of this, I know it's a lot of different information, is to try and really start to think about what are all these different drivers and characteristics of what we're seeing on a population level as it relates to opioid overdoses in the province. And it's really difficult to generalize, and this is something that I'm appreciating more and more, is how heterogeneous these populations are and how there's not going to be one approach that is going to solve any of the issues that we have. But I think that we do see some common patterns, is that when women die of opioid-related causes, they tend to be older, they tend to have been actively treated with an opioid recently by a prescriber, and they generally have other prescribed opioids that contribute to those deaths. And when we look at men who die of opioid-related causes, it's a slightly different population if we generalize. So they tend to be younger or middle-aged, and they tend to have illicit opioids and other illicit drugs in their system that are contributing to those deaths. So there is this difference in some of the surrounding factors related to these deaths that we can think about as well in trying to target our approaches to addressing this issue. I focused a lot on prescribing and outcomes, but I think the natural next question is, what about treatment? So if we're thinking about how to treat people who have developed an opioid use disorder, how does that differ? And how does perhaps access to and use of opioid agonist therapy differ across the province? So we've seen that prescribing to treat pain or cough is higher in women, but if we look at prescribing of methadone or Suboxone to treat an opioid use disorder in the province, about 2/3 of people accessing those treatment modalities are men. So we again see this flip, with men more likely to access treatment for an opioid use disorder. And when we look over time, those trends have been pretty stable. So consistently, women are less likely to be treated for an opioid use disorder, and it is access or use seems to be climbing over time, which makes sense because we're seeing this issue continue to evolve and grow over time, but we're not really closing that gap. And I think that raises an important question of whether this is an issue of access or different prevalence of addiction or opioid use disorder between these two populations. So is this that women are not able to access treatment for an opioid addiction, or is it that women tend to be less likely to have developed an opioid use disorder? And that's a hard one. I think if we think back to the figure where I showed you rates of non-fatal overdoses and how similar they are between men and women, I think that's indicative that we have a very similar distribution likely of opioid use disorder between genders. It's very hard to characterize on a population level using regularly collected data. It's just very difficult to determine. But it seems that likely men and women are very similarly being impacted by developing dependency on opioids. And so there's likely a really important factor of changing access or accessibility and barriers to access among men and women that is leading women to be less likely to seek and obtain treatment. And I think there are a few potential drivers from this that you can get from the literature and in some of the work that we've done. One of them is, I think, around power dynamics. So in these focus groups that we recently conducted and in speaking with women who've participated in methadone treatment programs, there's this great hesitancy around participating in that environment with some of the systems that are in place. So one of the parts of participating in methadone treatment is regular urine drug screens. And to make sure that it's really your urine, you have to have some kind of supervised sampling taking place when you provide that sample. And we heard many times from women who we spoke with that this is just such a degrading process for them, and oftentimes knowing that a man is in some way observing them providing this sample, just a huge barrier to them participating in these programs. And I have a quote here from one of the women we spoke with, but I think it's just indicative of some of those systemic barriers that exist within some of the treatment programs that exist. Another is childcare. So we know that women with opioid use disorder many times have children and families. And one of the barriers for methadone is that you generally have to go to the pharmacy every day for your dose. And it can be a huge challenge if you have children to either get childcare every day, or if you bring your children with you, the stigma that's already associated with having an opioid addiction, plus showing that you have children and that they're there when you're seeking your treatment, is enormous, and an enormous barrier to women being able to continuously access that treatment. And with methadone, it's very regimented. You have to be there every day and get your dose. And so, if things come up and you can't make it to get your dose, it can have serious consequences. And then finally, pregnancy is obviously something that is specifically relevant for the female population. And this has been in the news recently with some CHI data, I think, that was really showing that rates of neonatal abstinence syndrome have been rising across the province. This is a study one of my colleagues did looking at the number of infants born to opioid-dependent women and whether or not they had received treatment. So not only can we see that the number of babies born to opioid-dependent women has been increasing in the past decade across Ontario, but the furthest right bar with the horizontal lines represents women who were unexposed to agonist therapy during their pregnancy, and we can see that that has been growing considerably in the past many years as well, which suggests that there's really a gap there in terms of accessing treatment for women who are pregnant. And we actually did a study. I had a master's student work with me who did a study looking at women who were using methadone during pregnancy and trying to understand differences in when they access methadone and different outcomes. And something that really stood out from this study was that we found that women who were stabilized on methadone before compared to those who initiated methadone during pregnancy had huge differences in the rate at which their children were discharged to social services, so basically where their children were taken into custody. And we found in particular that women who started methadone during pregnancy had a 4-fold increased risk of having their child taken away directly from the hospital compared to women who were stabilized prior to becoming pregnant. And I think that highlights as well these huge barriers that women experience. If you have an opioid use disorder, you become pregnant, and you feel that your child is going to be taken away if people find out, you're much less likely to seek treatment for your opioid use disorder and to seek prenatal care. And so that adds all kinds of difficulties for women in terms of trying to manage their opioid use disorder and trying to keep control over their lives and their families as well. So I think if we're going to really try and address these issues, we need to think about how we can consider not only the drivers of all of these different patterns that we're seeing, but also what the policies and programs and systems are in place right now and how they're actually impacting different populations, how they're impacting women and other vulnerable populations in different ways that might make them less effective or actually, in some cases, perhaps cause more harm than good. And one of the emerging areas that I think is promising is broader access to Suboxone that Mel may speak to, and I know we've spoken a lot about this, but is an alternative to methadone where you can more quickly go to getting weekly carries. It takes away that requirement to go to the pharmacy all the time. There's more of a push to integrate Suboxone into primary care because there are less barriers for primary care physicians to prescribe it. And so there are opportunities like that and like the Medify work where we can bring together different systems that can really help address some of the barriers that have existed in the past for women and try and improve access to opioid addiction therapy in particular. We also know around harm reduction that that's a huge emerging area, because as we're seeing more dangerous drugs on the market and more people using illicit opioids, there's really a need to have harm reduction tactics in place to try and prevent people from dying of opioid overdoses. But we also know that there are barriers for women in harm reduction, and in particular, having to participate in a system where you might have to engage with men who have assaulted you in the past or who may have threatened you in the past. And as well, women who participate in some of these services or need these services oftentimes have a history of trauma, of sexual assault, of rape, and having to be in certain environments where they may not feel safe, or needing an environment where they have more supports can be very difficult to find. One approach to this is out in Vancouver, where earlier this year they opened a women-only safe injection site, and that was really designed to try and address some of these barriers and create more of a safe space for women to access harm reduction services. And they have a number of gender-responsive principles I've listed here, but I found it really interesting to read about the approach that they're taking to not only providing harm reduction, but also providing an environment and a community for women where they can promote connections with family and issues that might emerge around childcare and children, and making sure that they also have access to primary care that they might need. So this was a really interesting model that I think we need to start to think about more when considering how we can target some of our responses to different populations. And then finally, in closing, this is just a few quotes from these interviews that we've done, but as I mentioned at the outset, I think really engaging with people with lived experience is something that has been missing a lot from our response to this issue in the past, and is something that we need to integrate throughout these discussions, which is why it was so nice to see that video at the outset. I think we have so much to learn from people who are on the ground, living with the changes and the shifting environment as it relates to drugs in this country right now, and we can do so much by respecting them, listening to them, and learning from them, so that we can inform the research that we're doing, the policies that we're implementing, and the clinical responses as well that we have when engaging with this population.